All right. Good afternoon, everybody, and thank you for attending this session of Grand Rounds. I'd like to welcome our presenter for today, Dr. Ashley Wilde, who will be presenting on the topic of antimicrobial stewardship in ambulatory care. At this time, I'm going to turn the presentation over to Dr. Wilde.
Thanks, Chelsea. I'm happy to be here to talk again about antimicrobial stewardship, but this time we're going to be talking about antimicrobial stewardship as it relates to ambulatory care. But before we get into it, whenever we talk about stewardship and the development of drug-resistant bacteria, it's always important to talk briefly about where we came from so we can really figure out where we're going. And that actually brings us all the way back to 1928, when the Scottish scientist Alexander Fleming first discovered penicillin. He noticed that in his petri dish that had both bacteria and a mold penicillium on it, that the bacteria around that mold were dead. It was somehow fighting off this bacteria, and it produced the idea that perhaps there was something with this mold that was fighting off the bacteria. Now, it took actually quite a number of years before penicillin was available for patients to use. And in fact, the first American to be treated with penicillin was in 1942. So many years later. Her name was Ann Miller. She was hospitalized with sepsis, or what they called blood poisoning back in the day, due to complications from a miscarriage. And she had been sick for several weeks, extremely high fevers, battling this infection. They finally provided her some penicillin and she recovered successfully. In fact, she died at the ripe old age of 90 in 1992. And if it wasn't for that penicillin, Ann Miller maybe wouldn't have made it. And in fact, if you think about 1942, a lot of other things important worldwide were going on, including World War II. And the discovery of penicillin and the ability to treat soldiers actually really improved our care for soldiers, since a lot of them weren't necessarily dying of their wounds, but in World War II, they were dying from the infectious complications from those wounds before we had antibiotics. This really ushered in the antibiotic era. In fact, a very, very old professor emeritus that taught at Purdue when I was in pharmacy school was actually one of the scientists during World War II who figured out how to extract penicillin from soldiers' urine. So taking gallons and gallons of urine from soldiers who had been treated with penicillin to extract that penicillin back out so they could use it again in other soldiers. Penicillin was so important, it was even more restricted than morphine or painkillers back then because it was such a precious resource. But it didn't take us very long to figure out that overusing antibiotics can cause resistance. Back then, we didn't really have any issues with antibiotic resistance because no patients had been treated with penicillin. But it was actually still Alexander Fleming who had been quoted as saying, "The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to an infection with a penicillin-resistant organism." So Alexander Fleming himself recognized the importance of antimicrobial stewardship and talked about this as a societal issue about misusing antibiotics and who's responsible for what could happen downstream when we don't have antibiotics to treat patients' infections. So what do we do about this? How do we make sure that we are using antibiotics responsibly? And that's really where antimicrobial stewardship comes in. To answer the question of what is antimicrobial stewardship, most simply, it's a program to optimize infectious diseases clinical outcomes while minimizing the unintended consequences of antimicrobial use. Lots of patients do need life-saving antibiotics, but the question of how do we balance between those optimizing clinical outcomes and unintended consequences, oftentimes when clinicians are making a decision or people's perceptions of antibiotics often weigh much more heavily on antibiotics just in case this will help me feel better, just in case I have a bacterial infection. It often outweighs this nebulous unintended consequences. So today, when we talk about ambulatory stewardship, I really want to emphasize what those consequences are. So first and foremost, toxicities. Antibiotics have lots and lots of side effects. Antibiotics are actually the #1 cause of emergency department visits for adverse drug events in children. When you look at all patients, it's actually responsible for 1 out of 5 ED visits for adverse drug events. So antibiotics carry a lot of toxicities that should really give us pause before seeking out antibiotics. The other thing we talk about is Clostridioides difficile infections or Clostridium difficile infections. The estimated incidence is about 500,000 cases in the US annually. And for those of you who work in the acute care hospital or long-term care setting, the good news is that through infection prevention and antimicrobial stewardship, we're actually seeing decreased rates of C. diff in those areas. But the incidence in the community is actually on the rise. So the incidence of community-associated C. diff per 100,000 population increased by almost 30% between 2011 and 2017. So this idea that C. diff is just a healthcare-associated complication is no longer true, and we're seeing a lot of community-associated C. diff, which is why we're talking about antimicrobial stewardship in the ambulatory setting. And C. diff can be bad. 30-day mortality estimates in the United States to be almost 30,000 about 30,000 people per year die within 30 days, and about half of those are directly attributable to C. diff. And the care for C. diff is very expensive in the United States. We spend almost $5 billion a year in excess healthcare costs managing C. diff. So it's not just toxicities in C. diff, it's also about the development of resistance. So mortality associated with multi-drug resistant organism infections is high. We estimate that over 35,000 people in the US die annually due to an infection caused by a multi-drug resistant organism. And it's also, these organisms are also associated with increased length of stay and increased cost. And now the definition of multi-drug resistant organism, it varies from bug to bug and depending on who you ask. And usually it's like resistance to one or more classes or something like along those lines. But unfortunately, more and more common, what we're seeing are susceptibility reports like this, where we have no good options. And this is not some sort of like far-fetched, what if scenario where we don't have anything that we can reasonably treat. It's something we see like far too commonly, even here in Kentucky. And so if you're looking at this and thinking, well, this is fine because surely we have new antibiotics that can save the day, right? Alexander Fleming didn't really have to worry about penicillin resistance because we quickly developed new antibiotic classes to be able to treat penicillin resistant organisms. But unfortunately, that's just not true. Many people talk about us moving from the antibiotic era into a post-antibiotic era, because the last novel class of antibiotic that was discovered, that was eventually brought to human use, was discovered back in the 80s. So these antibiotic classes that really offer a novel mechanism, new drugs have just not been discovered for decades. In fact, I was at an infectious diseases conference last fall, and one of the keynote speakers that was talking about the threat of antimicrobial resistance brought up the date November 14th of 2022. So last fall, this date was just around the corner. But what they said was that November 14th of 2022 is going to mark the anniversary where no antibiotics have been approved in 3 years. So we've obviously had some new antibiotics. They're often Me Too antibiotics in the last, since 1984, maybe slightly different antibiotics with better toxicity or pharmacokinetic profiles. But honestly, we've been in just a total antibiotic approval void. Now, granted, we've been busy with COVID, but the pipeline of how antibiotics are brought to market really shows that the pipeline is just drying up. So we have to be very careful about how we use antibiotics, since new antibiotics are not there to save us. So that brings me to how we use antibiotics in ambulatory care setting. And we do have some data to help describe the use of antibiotics in ambulatory care. So we have good data from the United States about outpatient antibiotic prescription rates. So let's take a look. In 2021, there were an estimated 211 million courses of antibiotics that were dispensed in the US. That's a lot of antibiotic prescriptions, a lot of use in humans. There's even more use in animals, but in the United States, over 200 million antibiotic prescriptions per year. What's interesting is when you look at the appropriateness of these antibiotics, it's estimated that at least 28% of outpatient antibiotic prescriptions are unnecessary, meaning no antibiotic was needed at all. It was a condition where an antibiotic is not recommended. So we could say that about a third of those, almost a third of those, are totally unnecessary. Now, the same folks who look at antibiotic prescribing in an ambulatory care setting also note that up to 50% of antibiotics are inappropriate. And when they say inappropriate, what they mean is either it was an unnecessary use, it was an inappropriate antibiotic selection, so something that was too broad perhaps, or it was the wrong dose or the wrong duration. Now, there's a lot of different antibiotics out there, which might explain why some antibiotics were used more heavily than others. But this high rate of inappropriate prescribing is something actually fairly unique to antibiotics, where we just accept that a lot of antibiotics were completely unnecessary. And what I really like to challenge people to think about is, if instead of saying up to 50% of antibiotic prescriptions were inappropriate, imagine if we changed that word to something like chemotherapy right? So imagine if we said up to 50% of chemotherapy is inappropriate. We would not accept that as a society, that 28% of people who got chemotherapy didn't have cancer at all. Or perhaps we gave them the wrong chemotherapy, something that was too toxic, or maybe we gave them too much chemotherapy. People would not accept this, and yet we somehow allow this prescribing of antibiotics to continue year after year. So not every state uses antibiotics at the same rate. And fortunately, we have the data broken down at the state level to see how outpatient antibiotics are prescribed. And as you can imagine, here in Kentucky, part of the American South, we have very high antibiotic prescription rates per 1,000 population. So in fact, Kentucky is the 5th highest state as of 2021. We lag behind Mississippi, West Virginia, Louisiana, and Alabama. Our data shows that we have prescribed in 2021 938 antibiotic prescriptions per 1,000 population. The national average is 636. That's the average. That's not best case scenario, which means we have about a 50% higher prescription rate than average compared to other states within the United States. So obviously a significant opportunity for ambulatory stewardship here in Kentucky. So I want to talk through a case real quick to highlight how we can approach antimicrobial stewardship and some of the opportunities in ambulatory care. And specifically, I want to discuss some behavioral tools that can be used to enhance antimicrobial stewardship in the ambulatory care setting. So let's take our example. We've got this little old lady, 61-year-old female, who comes in with a chief complaint of coughing for a week. She said, I took some amoxicillin that I had and it just didn't help. Obviously, right off the bat, when somebody admits to you that they took amoxicillin or some antibiotics that they had at home, this should prompt a conversation about using either leftover antibiotics or other people's antibiotics and how that is less than ideal. But with her situation, her past medical history is not notable for anything significant other than anxiety, depression, and fibromyalgia. Social history shows that she's an occasional smoker, but she works from home and has no sick contacts, and she has no known drug allergies. When reviewing this patient, she was afebrile, her pulse was 75, her respiratory rate was 17, and her oxygen saturation is appropriate, 96%. In reviewing the patient, she does have a positive productive cough. She notes yellowish, greenish tinged sputum. She does endorse a sore throat as well as a mild headache, but denies any shortness of air or shortness of breath. On physical exam, her lungs are clear to auscultation, which is good news. And since it's 2023 and we can't predict when literally any respiratory virus is going to be in season or not, we go ahead and get a point of care combination COVID-19 flu and RSV test, which was negative. So with all of this information together, the fact that she has a productive cough, a sore throat, her lung exam is clear, she doesn't have a fever to note, we're working with a presumptive diagnosis then of acute bronchitis. So many of you can relate to having acute bronchitis. It's very common in adults. So in thinking about what would we do with this patient, I want you to think about which of the following would be most appropriate. Is this a case for, azithromycin dosed like a Z-Pak? People love Z-Paks, they're very convenient. Would it be more appropriate to use something like levofloxacin, which if you've attended several of our antimicrobial stewardship presentations at Grand Rounds, you'll know that levofloxacin or other fluoroquinolones are not often our preferred option for treatment of infections. Would it be more appropriate to prescribe or refer for doxycycline as a 7-day course? Or for this situation, do we offer no antibiotic, but rather supportive care or symptom management? And so in thinking about this with acute bronchitis, the recommendation is emphatically and pretty clear, no antibiotic. And supportive care and symptom management is the best way to proceed. And the reason I bring up acute bronchitis is upper respiratory tract infections, like rhinosinusitis, sometimes is viral, sometimes bacterial. The management could be adopted from several of these principles, but bronchitis is also very common. So I wanted to quickly review a brief ins and outs of acute bronchitis. So specifically, bronchitis is the presence of a cough with or without sputum production that lasts usually less than 3 weeks, although some people are still coughing for several more weeks after that. And it starts in the setting of a viral upper respiratory infection. Many patients endorse first having a sore throat that then they feel is progressing into a cough. And it's really this symptom progression that gives people a lot of pause and why they seek out clinical care. Something that started as just a sore throat and now they're feeling worse is usually the normal trajectory for acute bronchitis, although it can be concerning to patients. Purulent sputum or wheezing does not indicate a bacterial infection and cannot be used to differentiate between a bacteria or a viral infection. And so antibiotic treatment for acute bronchitis is generally not recommended. And it's been studied. It's not something that we are just guessing at. Acute bronchitis, antibiotics in acute bronchitis have no impact on the severity of the cough. They have no impact on the duration of the cough. So it's not going to make them feel better. It's not going to lessen the severity, and it's not going to shorten the course of symptoms that they have. And it does not prevent complications like asthma exacerbations, bronchiolitis, or progression to pneumonia. And the reason being is that it's viral. The vast majority of these acute bronchitis is viral. So it's very easy for me as a pharmacist who really focuses on spectrum of activity to say things like antibiotics don't treat viruses. But when I'm engaging clinicians, we have to be cognizant of the fact that avoiding antibiotics in viral upper respiratory tract infections is not easy. And partly because we live in a culture where we expect antibiotics, and you can see that patients seek antibiotics and want something to help them feel better. And there is this perception that antibiotics are all benefit and no harm. So I want to take us a moment to talk about some office-based strategies at several time points where we can execute some antimicrobial stewardship principles to help change people's perceptions on how we can avoid antibiotics in acute viruses. So the first being pre-visit communication. And there was a study, very interesting study about using triage nurses and their ability to prevent unnecessary visits for upper respiratory tract infections. Because if you could keep patients from coming in and seeking additional care and seeking additional antibiotics, then a lot of that reassurance can be avoided, and there isn't that pressure for providers to prescribe an antibiotic. So in this particular study of almost 300,000 calls to a triage nurse, self-care advice was sufficient in 88% of cases. So counseling the individual that cold symptoms are caused by viruses, unfortunately, we do not have medicines to cure a cold. Giving that advice that they don't necessarily need to seek additional care was enough for most people to say, you know what, as long as you tell me it's okay, I can wait this out. Other messaging that was included is if you feel comfortable managing your symptoms at home, you can save yourself a trip to the office. Giving people expectations on how long your symptoms will last, like your symptoms will likely last around 7 to 10 days. If your symptoms continue or become severe, or if you prefer a visit now, we'd be happy to see you right away. And self-care advice was, like I mentioned, was sufficient in 88% of cases, meaning these individuals did not seek out a visit at that time and did not follow up with any additional care. So a great way to just avoid those visits overall. Other communication strategies that can be used ahead of the patient talking with a provider is educating check-in staff about communicating on antibiotics. Because when people come in and they're not feeling well, they come in and they say, you know, I'm here to see Dr. So-and-so, there's this strong need for a lot of individuals to empathize with how they're feeling. And we need to be careful about how even those individuals who check in staff are communicating with patients about expectations. We want to naturally say something like, oh, I'm sorry you're not feeling well. Dr. So-and-so is going to get you feeling better right away, or we're going to get you fixed up right away. And that sets the stage that the doctor will be able to do something today that will make them feel better or get them fixed, cure their infection. So we need to be careful about how we communicate with individuals about expectations that will help set the stage for their visit. So speaking of setting expectations, we can also provide patient education materials. I know every doctor's office waiting room has some sort of posters or TV screens. There are a lot of resources out there from the CDC and other organizations that really provide these great visuals. So this poster in particular talks about how antibiotics are the wrong tool to treat a virus. And she is just going after that cantaloupe while her family looks on shocked while still somehow wearing appropriate eye protection. But having these things in there is a passive way to help orient patients to expectations on antibiotics. Other interventions or sort of patient education materials that have been studied around ambulatory antimicrobial stewardship include exam room posters where physicians post these commitment posters that exemplify that they are committed to only prescribing antibiotics when they will help you. This really does help to set the stage that sometimes antibiotics are not needed. And we will explain this to you and offer you other options that will help, but noting that antibiotics will only be prescribed when they help you. And so in a study, a controlled study over 12 weeks, it was noted and published that there was almost 20% absolute reduction in inappropriate antibiotic prescriptions for acute respiratory infections because of commitment posters like the one that's on the slide here, letting patients know that we as prescribers are working on your behalf and really commit to using antibiotics as a tool only when they are necessary. Now, the way that we educate people about antibiotics can help some, but ultimately how we communicate with patients about antibiotic decision-making is going to be really important. So there are tools and tips we can go over about how to be a good communicator about antibiotic decision-making. So ultimately, if the decision is being made to not use an antibiotic, communicating certain strategies really helps patients feel like they're being heard, feel like they're being validated. So a strategy to help patients feel heard is that you can repeat back to them exactly what they've said to you. So what I'm hearing you say is repeat the main concern. Oftentimes when clinicians say, I'm not going to prescribe an antibiotic or it's just a virus, patients may not feel like you actually listened to everything that they said. And therefore you are not making a decision based off of all the information that's needed. So you can sit at eye level, making sure that you're giving them their attention, nod your head in agreement when they're talking instead of interjecting words like, it's just a virus. When examining the patient, you can verbally state the pertinent negatives based off of your review. So as you're assessing their fever, you can say, good news is you're afebrile. Good news is your lungs sound clear and you're not wheezing. These can help set the stage when ultimately the communication on antibiotic decision is being made. Patients want to feel validated when talking about antibiotics. So we don't want to feel like they were in the wrong for coming to see you, like they should have known better. So something like, I'm so glad you came in today. I'm sorry you're not feeling well. It sounds like you're not feeling well. Let me see how I can help. Making sure that they didn't feel like they were in the wrong for coming to see you. One of the important things that we can do to help change the narrative is talking about antibiotic non-use in a positive way. So instead of saying you don't need an antibiotic because it's just a virus, right? That sounds very dismissive. If we reframe it into the good news is you do not need an antibiotic. We could say, fortunately, you do not need an antibiotic. So here are other things that we can offer you. Framing it up about antibiotics being problematic is really helpful. So if we say, we now know that sometimes antibiotics can cause more problems like diarrhea, the good news is that I can offer you a couple of good options today. Those who have studied these types of implementation strategies really point out that giving patients two options and letting them understand why you're selecting one over the other helps them really just feel part of that decision-making process. So if you say, antibiotics won't help you feel better and can cause harm or make you feel worse, versus we can do something that will help with your symptoms and can help you feel better today. Those two options, when weighed against each other, helps the patient understand that you did consider multiple options, and this is why we're going with that course. And last but not least, patients want to know about when they will feel better and what they need to do to return for medical attention. So providing details about when the patient is expected to feel better, guidance, when to return to medical care, and then ask if you can to have the patient repeat the plan to avoid any misunderstandings. A lot of clinicians can use these symptom management one-pagers that have a lot of options to guide patients on what to use over the counter for which symptoms. I know a lot of patients get a lot of confusion when trying to navigate the cold and flu aisle when it comes to which OTC drugs will help them with which symptoms. So providing treatment options for acute bronchitis or other respiratory infections that really helps them know that this is going to help with this symptom and what to look for, since oftentimes you go there to the cold and flu aisle and it's just the same brands all saying cold and flu, cough and cold, that sort of thing. The last piece I want to talk about as far as strategies actually comes from an article from a pediatric infectious diseases pharmacist that actually works with some data here in Kentucky as well. And it's talking about post-visit office staff communications. We talked about, check-in staff, the provider working with the patient. But if the patient has left and is still dissatisfied about the antibiotic decision, they can be trained, those that are checking patients out, on how to respond to some patient comments as well. So if a patient says, the last time I had this illness, antibiotics cleared it up right away, even the most basic of individuals in this country should be able to understand that colds are caused by viruses and do not require antibiotics. If they say something like, I can't believe they wouldn't prescribe me an antibiotic, instead of arguing with them about, Dr. So-and-so, he doesn't, he's really busy and saying that was, somehow an inappropriate decision, you can often do the same thing we talked about before, where you can talk about antibiotic non-prescribing in a positive way and say, well, at least you don't have to worry about those nasty side effects that they can cause. If they say that this appointment was a waste of time, basically reiterating that they didn't get what they wanted or they didn't get what they came in for, you can be reassuring and say, it's still good that you came in. It's always reassuring to know that you don't have something more serious going on. And ultimately, if they say, I guess I'll have to go somewhere else to get what I need, I'm sorry you're dissatisfied with your care, I can assure you that Dr. X or Dr. So-and-so is committed to providing the best care to patients. And sometimes antibiotics can cause more harm than good. And I think that last statement about sometimes antibiotics can cause more harm than good is a really good takeaway message that anybody who has contact with anybody in the healthcare system can reiterate. Because antimicrobial stewardship really is for everybody. We often think that pharmacists have a lot of antibiotic training and prescribers are ultimately the ones who have that pen, or I guess maybe the login to be able to prescribe the antibiotics. But how we approach antimicrobial stewardship, particularly on a large scale, requires everybody's effort. It requires consistent communication of expectations on antibiotics, how antibiotics work, and ultimately, if everybody can get on board with the fact that antibiotics can cause more harm than good, then that scale that I mentioned at the beginning about antibiotics just in case versus the harm of antibiotics, we can start tipping that scale as a society and hopefully tip our antibiotic prescriptions towards more appropriate prescribing. If you work in the ambulatory care setting or you're interested in learning more about antimicrobial stewardship and ambulatory care, there's a lot of good resources already available out there. The CDC has a Be Antibiotics Aware campaign that has a lot of great educational materials in so many different formats, whether it's posters or brochures, videos, social media work. They've got a lot of great materials that have already been created that are really crafted to help set the stage and send a message about what's got you sick, do we need an antibiotic or not. They also have resources for how to implement antimicrobial stewardship in outpatient facilities, if that's something that you're interested in. Another great resource for ambulatory antimicrobial stewardship is AHRQ, which is the Agency for Healthcare Research and Quality. So they take the approach about defining the 4 moments of antibiotic decision-making as their core method for implementing antimicrobial stewardship. So moment 1 is, does my patient have an infection that requires antibiotics? Moment 2 is, do I need to order any diagnostic tests? 3, if antibiotics are indicated, what is the narrowest, safest, and shortest regimen I can prescribe? And moment 4, does my patient understand what to expect and the follow-up plan? So sort of a holistic approach to antibiotic decision-making. They've got some great toolkits as well on their website if you're interested in learning more from AHRQ. And of course, last but not least, we have the CASIC, which is what we're here talking about every month. If you have any issues or questions with antimicrobial stewardship, although we are not actively doing a lot in ambulatory care, we are always happy to answer questions related to antibiotic stewardship. Our website's up there. If you want to contact me directly, that's my email address. I just wanted to highlight too as well that, if any of you are on social media, we recently started using Twitter to send out antimicrobial stewardship case-based education, where you can participate in our poll. So if you want to go and follow us on Twitter, each week we'll send out a poll, kind of like the one that I display here, although much less characters since it is on Twitter, to really test your antimicrobial stewardship knowledge and the application of some of the principles that we educate on a regular basis. These polls also contain answers to those sort of patient case examples and give our take on why one option is perhaps preferred over another. And so if you want to sign up for any of that, again, the website will have hyperlinks to everything. That QR code on your screen will provide you a link to our website as well. So with that, I thank you for your attention. And if anybody has any questions, I'll be happy to answer them at this time.
All right. Well, thank you to thank you to Ashley for this wonderful presentation, and thank you to everybody that joined us this afternoon. I invite you to join us next week where Dr. Tim Wimkin will be discussing the topic of large language models. I look forward to seeing everybody then.